Hello. Dr. Holly Hampy, I'm the Program Director for the Health Administration Program at RMU, and this is our Day in the Life of series, and today we are very fortunate to have AJ Harper. He is from Hospital Council, and he is the president of the organization, and welcome, AJ.
Thank you, Holly.
Appreciate you being there.
Pleasure to be here.
We're going to be talking about his role as the president of Hospital Council and some of the things that he's been involved in. And first of all, how did you become the president of Hospital Council?
Well, I was in Cleveland, Ohio, although I'm from here originally. Most of my career was in Cleveland. I was running a freestanding cancer center and followed the American College of Healthcare Executives website and simply was in there looking at jobs and exploring CEU opportunities and found the opening online for the Hospital Council of Western Pennsylvania. That was 10 years ago this July. Celebrating my 10-year anniversary. So I would say to the students, the American College of Healthcare Executives, a professional organization that provides you with a lot of different opportunities, and one is a job bank, and that's what led me to this position.
So networking is pretty important in the role that you're in, and having a job, getting a job, staying in a job.
Right. Absolutely. Any association, and particularly a regional trade association such as the Hospital Council of Western Pennsylvania, is really one of networking. It's one of facilitation and bringing people together and sharing best practices. So we do a lot of networking, and I would say again to the students throughout your career, it's integral to maintain that network, both professionally and through your professional societies.
Well, you didn't just step into that position. You had a number of things along the way. Can you tell us about your educational background and your experience that prior to becoming president of Hospital Council?
My interest in healthcare actually started being from Beaver County with the old J&L Steel Mill, who had a Health Explorers career opportunities and at the old Alcoa Hospital, and where you spent every Saturday and went through a different ancillary department to learn about that department. I quickly found that I didn't have an interest in direct patient care, but did still have an interest in hospitals, and so took the route and interest of healthcare administration. Now, as you know, healthcare administration now has a bachelor's degree. At that time, it was only a master's in health administration, so I had to select an undergraduate degree to pursue my course. And so I selected what was at that time known as medical record administration, now known as health information management. And I was interested in that profession because it places an individual across the continuum of the hospital operations. Research with databases, working with physicians, regulatory issues such as Joint Commission, managing individuals, working with finance and reimbursement, the opportunity to provide data and be part of marketing and planning, strategic planning. So it was a great step for me into hospital administration. So I looked at programs and went to the Ohio State University for its program in health information management. And from there, I went to the Cleveland market, where I was an assistant director of health information management, working my way up to a director position. And at that point in time, in 1982, was the beginning of prospective payment, or as you may know it, the implementation of DRGs, diagnostic related groups. And the entire field and realm of prospective payment offered new opportunities to go in and understand IT systems. It was the automation not of the medical record, but the automation of insurance files, the automation of registration processes, the automation of data registries. And in addition to that, the insurance companies started to do more appeals and denials work. We had the peer review organizations initiated. So my path in career was all through working with medical staff, working with quality assurance, utilization review, survey process, compliance, and gradually over the course of my career, there would be one new regulatory matter after another, the Balanced Budget Act, HIPAA, Y2K. And so my career has always been through the non-revenue generating, non-clinical support side of the house, not finance, but those departments. I eventually went from an inner city hospital to the Cleveland Clinic Foundation, where I spent 13 years and became the Director of Patient Access. And from there, went into the Board of Governors as an administrator, and I was the administrator for medical operations, which was really project-oriented. I worked across all the divisions of the Cleveland Clinic and worked on a variety of patient care projects, workflow redesigns, initiatives with data and quality. It was quite exciting, enjoyed my opportunity there, and then went to the Greater Cleveland Hospital Association, spent 5 years there as the Vice President of Professional Services, which is where I got my association experience. And then back into hospital operations, and as I mentioned, running a freestanding ambulatory cancer center, so I added the hat or the tools of a practice administrator. When I saw that the job was open to come back home to the Hospital Council of Western Pennsylvania, I pursued that. So my career, Holly, has been one of really, again, in the healthcare setting as a health administrator. I had an opportunity to run a few clinical departments, home healthcare services, clinical nutrition, dietary offices, but never really went into allied health or the nursing arena.
You know, one of the things that the students are wondering about is how do you get your first job? How do you make that first step into health administration? And I know you've touched upon it. What do you think was the impetus for you to get that first job? Any words of wisdom on that first entry?
I would say that it may sound outdated, but obviously a solid resume. And then obviously the opportunity to get in and get that interview. And so I would think that internships, networking, whether they're internships paid or unpaid during the course of your work as an undergrad, or if you're already a careerist and you're making a career change or you're pursuing a master's degree, obviously the networking within the organization or entity with which you're currently employed. To be able to reach out to an administrator in another division or physician leader and to spend time and understand that area or opportunity leads you then to options and for employment and opportunities for that job opening. If you're coming out as an undergrad, it's simply a strong resume, a well-written resume that's going to get the attention of that recruiter, and it's going to be the interview. And for me, Holly, in the end, and I would say to you, all of you, if you end up in the management realm, it's all about communications. It's all about direct communications. It's all about your presentation skills and how to really get in the door. Once you're there, the skill sets that you have, the toolkit that you've put together through your undergraduate learning will then take you where you need to go.
You know, with internships, it's one of those, you know, if it's a chicken or the egg, you have to have experience to get a job, but you have to have a job to have experience. So it's one of those having an internship that will help to bridge the gap between not having enough experience. And I think that you're exactly right. Now, your position as the president of Hospital Council, what does that entail?
Well, first of all, let's explain the Hospital Council, soon to be renamed the Healthcare Council of Western Pennsylvania, to reflect our work in supporting providers across the continuum of care. So as a trade association, we are a 501c3 nonprofit dues-based trade association. You will find that every state has the State Hospital Association, which primarily deals with lobbying on the Hill and the Capitol and working with legislators and regulatory agencies. There are about 21 regional metropolitan associations around the country, of which we are one, and we are more geared towards project management. So our mantra is to convene and facilitate groups. We work off a committee structure, but we really are here to support the C-suite and support key management positions within each of the hospitals, long-term acute care hospitals, and long-term care facilities and specialty hospitals. So again, we're across the continuum of care. As president, obviously my job is to lead that organization, and a lot of my time is spent with the C-suite, with the CEOs, the COOs, the CFOs, trustees, medical staff leaders, and trying to make sure that relationships and issues that occur between members, i.e. providers and purchasers, or providers and payers, are positive as they can be, move fluently. We do a lot, again, as mentioned, project management. We use the words convener and facilitator a lot. So we try to bring groups together, bring members together to share best practices so that individuals can walk away with something learned, some value add they can take back to their individual facility. I have a staff, of course, that does that legwork, but as the president, my job is to really provide that overall leadership and vision to that end.
Now, who would report to you and who do you report to?
Well, we have a relatively small staff. I have a vice president of payer relations and reimbursement. I have a vice president of clinical services. I have a vice president of professional services. It's the four of us in a nutshell. Obviously, payer relations and reimbursement deals with Medicare issues, Medicaid issues, and commercial health plan issues. Professional services individual deals with compliance, risk management, handles communications, advocacy, some lobbying. We do some lobbying, Holly, so that individual leads that initiative. And then my VP of Clinical Services and Quality deals with chief nursing officer issues, regulatory issues from the Department of Health, as well as quality issues. A couple of administrative assistants and a data person, and you can talk about our data reports in a minute, and the maintenance man. So we're small, but very concise, but do a good job. I report to a board of trustees, a board of directors at Hospital Council. That board of directors is made up of 26 individuals. I am the 27th by virtue of the office. The invitations go to the CEOs of the hospital. And if the CEO cannot or doesn't have a desire to participate on the board, we will ask for a chief nursing officer, a chief financial officer, a trustee, a chief medical officer. So we try to get a blend of C-suite individuals to serve on the board. We also have 3 at-large positions, and those are filled currently by the Dean of Nursing at Duquesne, so we try to have academia involved, someone from public policy. We have a physician from the Allegheny County Medical Society. That board meets 4 times a year. They have the fiduciary responsibility, and as president, I report directly to that board.
What are some of the projects that you've been involved in the last year?
Obviously, the Affordable Care Act has been on everyone's mind, and I'm sure we'll have questions specific to the Affordable Care Act before we close today. But it's really, when you look at the projects that we're involved with, we are working with the health plans. We don't do contract negotiations. We don't discuss rates. That's not our role. But we do talk to the health plans about the rollout of certain policies or procedures on quality, on regulatory issues, on reviews, and we try to create relationships there. So we're constantly dealing with the health plans. At the federal level, we have an issue on what is called the Area Wage Index, and to not get into too much detail, it could be a lecture on its own sometime for the students. It is the labor component that makes up the reimbursement rate of the DRG for Medicare. And the wage index varies around the country. It rises from a high of about 1.75 in Northern California to a low of 0.77 in West Virginia. Unfortunately, in Western Pennsylvania and Pittsburgh, we sit at a rate of about 0.85. So Holly, if 1 is the average, that means at 0.85, you are 15% below the average on the formula to determine the rate for payment for Medicare. So we are constantly working on the wage index issue. There are a lot of flaws in that. This is where we might get into a little bit of lobbying. We work with House reps and state and our senators in an effort to address our concerns about wage index. We work with other state hospital associations. That's taking a lot of my time this past year. It's been a constant project for us. And then basically it's really working with the CEOs and creating relationships. Strategizing. I've done this year a lot of board presentations. Boards are now sitting there, the boards of the respective hospitals or post-acute care providers or specialty hospitals are saying, what's our future? What are some things we should be looking at? AJ, can you tell us about the market nationally? Can you tell us what's happening at the state level? Can you come in and facilitate our board retreat to help us make a decision as to whether we should merge with a nonprofit health system, merge with or be acquired by an investor-owned chain, stay the course, change our service line. So the facilitation skills, which come with good communication skills, Holly, are something that's really been the majority of my work over this past year.
You know, one of the things that we've been talking about is that wage index and why it is different in every state. Could you briefly, why is it that the wage index fluctuates so?
Well, the wage index, obviously, let's take this story of Pittsburgh. In 2002, 2003, the wage index was at about 0.94 or 95. It tumbled to where it is today. And as I mentioned, there are wage indices that have a wide range. I believe that in Pittsburgh, there were 2 factors. One was the, one was the dominance of Highmark, the Blue Cross commercial insurance plan in Western Pennsylvania. And this is nothing demeaning or sinister. Highmark simply did their job. They were able to keep premiums down. They were able to negotiate very good rates with hospitals that favored the employers because there was not commercial insurance competition in the market. Example, in the Cleveland market where I came from, there were 4 commercial insurance companies that had 18 to 25% of the market. As a provider, when you have competition, you can negotiate better and get better rates for your commercial population. So the hospitals in Western Pennsylvania have always worked on close to Medicare rates. and they've been lean and mean. They've worked hard to do that. There's been, and we've adjusted to that. Likewise, as I mentioned, then the employers in the area have benefited from the Highmark plan during these years to provide rates that were very competitive. Now we're getting more in commercial insurance competition. The UPMC health plan, Aetna, United are now having more of a presence. But that's now. So the question was, what led up to the issue with the wage index decline? So I think for all those years, having a lack of commercial insurance competition kept premiums lower, kept rates lower, and hence hospitals could not offer as many increases or a rate of increase as other areas of the country did. Second, I would say, this is my hypothesis, was the closure of St. Francis. And when St. Francis closed, we did not have a mass exodus of clinical workers going to the Carolinas, Florida, or the Southwest. Pittsburghers stayed in Pittsburgh. And so to that end, we never had critical shortages in healthcare positions. Again, in my time in Cleveland, what we called, during the same period of time, we had what we called the wage wars, where we had to recruit in the competition for nurses, nurse anesthetists, coders, physical therapists, really increased wages rather rapidly. And so in the end, Holly, the short answer is that nationally, wages increased 42% over the last 10 years, but in the same period in Pittsburgh, wages increased 21% because we had less margin to work with. So by not having the demand for shortages, healthcare shortages, we didn't have a wage war, and we were dealing with, I think, tighter budgets that now everyone around the country is seeing. I know that's a question for a little bit later, what's causing fluctuations in the market around. So that was really, I think, the two issues that really started the issue with wage index. And then once your wage index lowers and someone gets higher, as you're providing increases, it's kind of get into a tailspin, so to speak. So unless you can drastically raise your wage index, or you can get some type of corrective action through policy or through a political opportunity, you continue to suffer at a lower rate, and that's what the issue has been in Western Pennsylvania.
In Western Pennsylvania, it's not a secret that Highmark and UPMC have had their share of disputes. Has Hospital Council got involved in that at all to help resolve that issue?
No, we really are Switzerland. That's the role of a metropolitan association. Both UPMC and the Allegheny Health Network are members of the Hospital Council. As a matter of fact, one collaborative initiative that both the Highmark Foundation and UPMC Health Plan participate in is a regional health literacy coalition, which is housed in Hospital Council. So we work with each health plan, again, to address issues on operational issues, policy issues, quality issues, issues around appeals and denials, but we do not get into discussions on negotiations. And again, being a neutral player, everyone takes the armor off and comes into council to try to advance what's best for the community, for the patient, and provide, again, best practices for each one to learn from.
Good. As far as the CEOs that you've been speaking with, what's on their mind besides the Affordable Care Act and decreased admissions and readmissions and?
Well, that is what's on their mind. So let's start there. Obviously, the Affordable Care Act, people, and I mentioned this, Robert Morris had an event a couple of months ago, which we spoke on a panel, and I made this statement, and I'll make it again for the students today, and that is that I don't care if the Affordable Care Act gets repealed. AJ, why do you say that? It's important. It affects your livelihood. There's so many lives at stake. It's so politically charged. Why do I say that? Well, if you would go to Washington with me and you were sitting in with either current members of the House and Senate, whether they're Republicans or Democrats, or former members of Congress, they will tell you there's a lot that they like in the Affordable Care Act. Obviously, what you're hearing about and the matter going before the Supreme Court is how it's paid for and the constitutionality of taxes and the constitutionality of how it's funded. But in the core of the Affordable Care Act is a large section about quality and about transparency. And that is where Republicans and Democrats agree on and like the wording in the legislation. So those things that are important to my dues-paying members, those things that they're focusing on, improving outcomes, reducing readmissions, and reducing hospital infection rates, being more transparent in their pricing, being more transparent in their reporting. We encourage that. We embrace that as an industry. And that's not going away, and that's where our focus is in regard to the Affordable Care Act. Now, other components of the Affordable Care Act have been, and the reason why the American Hospital Association and many hospital associations like ourselves supported the ACA, was the fact it provided coverage for the uninsured. And if you look at the numbers of charity care and uncompensated care that occur here and nationally, you can understand why hospitals and all providers wanted to see coverage for all. Extended coverage for individuals to the age of 26 under their family plan, elimination of pre-existing condition. So the ability to provide coverage means that individuals will seek care, and if they seek care early on in the prognosis or progression of an illness, obviously they can have a better outcome, they can be managed better, utilization goes down, costs go down. And so that is why the massive support by the hospital industry in regard to the Affordable Care Act. Obviously, the King-Burwell matter before the Supreme Court will determine if, in fact, state exchanges are constitutional or not. Those state exchanges that are funded and supported by the federal government. It's a linguistic issue, it's a wording issue. I think it's too detailed to go in for the purposes of our interview here today. But that will affect the possibility of how individuals who now have coverage in the state of Pennsylvania and across the country, how will their coverage be affected? And there's going to be a reaction to that. And what are individuals going to do if in fact they lose that coverage? How's that coverage going to be maintained? How do we continue to encourage people to see their primary care physician, to see a nurse practitioner, to go to a clinic, to get preventive care, to get that flu shot, to get that pneumococcal vaccine? So it's quite an interesting dilemma. So to your question, that is still on everyone's mind. Mm-hmm. I think second to that, obviously, is that the whole movement towards a bundled payment methodology or some kind of global payment, along with the economic decline that we have seen, means that we have seen a large reduction in admissions, and we've seen drops in inpatient volume. We've even now seen drops in outpatient volume. People are having to make a decision, Holly, as to whether they pay the utility bill, they put food on the table, can they meet their high deductible payment, do they want to hold off for some reason in getting care at a local facility or at their physician office. So volumes are down, and that's a concern, as you mentioned. I think that the outside of those two things, if there's anything else we need to be concerned about, is the fact that with shrinking reimbursements, there are less dollars available for capital improvements. So of course, students know you have your operational budget and you have your capital budget. And historically, I had a CEO make a good analogy. He said that capital budget was always for plant, property, and equipment, and then of course clinical equipment to get that new lab for colonoscopy or to get a new piece of imaging equipment. But now our hospital CEOs have to spend those dollars between clinical equipment, plant, property, and equipment, and technology. So the cost of implementing the electronic health record, the cost of advancing the new technologies that you need to stay relevant in today's world, in today's society, in delivering healthcare, telemedicine, all of those things that come into play in regard to technology. And I think it's important for you as students to really stay on top of the technology that's out there, that's happening. Even those technologies that we're getting on our smartphones, those apps that are helping us do preventive maintenance and preventive care and measuring of metrics, of health metrics, is very important. But the shrinking budget at the federal level, which we can talk about, the shrinking budget at the state level, and these demands for technology revenue, technology monies, and monies towards plant, property, and equipment, I say is probably right up there with the Affordable Care Act and with the whole move towards population health and declining utilization of inpatient activities.
On the other side, we've got finance, importance with finance and quality. The movement from a volume-based to a value-based. Has Hospital Council been involved in that shift and making sure that there is value to the healthcare?
Excellent question, and the answer is yes. Jay Montgomery, who is my Vice President of Clinical Services and Quality, actually thinking of a title change to Vice President of Care Transitions. And we have engaged more long-term care, CCRCs, continuous community living, regional living communities, specialty hospitals, working with and our hospitals themselves, developing medical neighborhoods. So the whole intent of moving care outside of the four walls to ambulatory or outpatient setting. And that can be done, it's being forced by the health plans, it's being forced by constraints on economic availability of individuals to holding off on and having surgeries. I mentioned that, so volumes are down. But it also has a lot to do with our work. And again, we're healthier. With the pneumococcal vaccines, with all the preventive care, with the ability to get screening, with advancements in technology, with minimally invasive surgery, we have really created a healthier population. We've created more being done in the outpatient setting. So what's left then is the idea of bundled payments, shared savings programs, where we're saying, okay, now that the dust is settled and we are continuing to move people to the outpatient setting, we need to develop a payment model that really covers that continuum of care. And that continuum means from the physician's office all the way to palliative and hospice care. When you look at the payment models that are out there, and this is again under the guise of value-based payment, there were four. And on the four payment models that were offered by CMS Medicare early on, only one dealt with the relationship and the payment between the physician and the hospital. The other three models, if you look at them, talk about post-acute care. And post-acute care, the episode of care can be identified as anywhere from 30 to 60 to 90 days after discharge. So now you're talking about a payment scheme that's going to not only cover the physician in the hospital, but cover the durable medical equipment company, cover the community pharmacy, cover the nursing home, cover the rehab facility. And that's where you're finding greater relationships between acute care providers and post-acute care providers. Lancaster General Hospital, Tom Beeman is the CEO there, a very forward-thinking individual, has hired a VP of post-acute care services. And that individual is simply there to work with the providers post-discharge to create relationships. Not just, hey, how are you doing, and can we fund something, and can we do some education together, but making available components of their Epic health system, portions of the electronic health record, so that those post-acute care providers can get that information and see the clinical information, see the demographic information, see the insurance information, so there's not gaps in service, so that the handoff from the patient between episodes of care, between levels of care along the continuum are not interrupted. And so that movement's happening, yet we're still under a fee-for-service payment methodology. So you're finding that if you are more efficient, if you can discharge early, if you can avoid the admission, you're actually still hurting your revenue while you're still operating a boiler, lights, coverage, a facility, an aging facility. And so it's quite interesting, the dichotomy is occurring right now as we move from volume-based to value-based. I think we're moving rather rapidly, and I think within the next few years we'll see that. I will also give you another example of, you've heard about ACOs and you've heard about other shared savings initiatives, and I had the pleasure of speaking with an individual on a panel who came from the Presbyterian homes, which are located in the central part of the state, and a hospital out in the east, St. Luke's, I believe is in Hazleton, don't hold me to that, came out and said that about 75% of our inpatient volume is wrapped up in these 34 DRGs, and we would like to go out and we'd like to submit to Medicare a model proposal for a global payment, a value-based payment model, and we'd like to reach out to you, Presbyterian Homes, and we'd like to reach out to this independent physician group practice, and we'd like to reach out to this durable medical equipment company to come in on us with a bid to manage this population. So that's the one that I've seen closest to home, Holly. We haven't seen a whole lot of ACO activity here in Western Pennsylvania yet. Every market's different. You've seen one market, folks, you've seen one market. So things I'm sharing with you in the Pittsburgh market may not even appear or exist in the market that you land a job in. You can say, what was this guy talking about? Because I'm not seeing it here in Cleveland, I'm not seeing it in Buffalo, I'm not seeing it wherever I am in the country. But it is moving that way, and I would think well within our, quote, work lifetime, we will see more employed physicians, we're going to see larger integrated health systems, and we're going to see payment models that really are comprehensive from acute to almost hospice or end-of-life care.
You know, you'd said about the volume and valued just hasn't caught up yet, similar to like readmissions. Hospitals are trying to avoid readmissions, but they're now decreasing their volumes and not getting paid for that readmission. And what are your thoughts on the penalties that are being put onto hospitals regarding quality metrics as well as readmissions?
Well, if we break out the readmissions from the other quality metric, I think that's first and foremost. On the quality, on the readmissions, we really have two categories of readmissions: planned and unplanned. And so, for any planned readmission, we should not be getting penalized, because if you're following best practice guidelines, if you're following clinical standards, evidence-based protocols, and it requires a sequence of hospitalizations or a planned hospitalization, then you should not be punished for that. On unplanned readmissions, they really fall into two categories, and one would be the unplanned readmission where somewhere in the discharge process we drop the ball. It could be on a medication reconciliation, it could be on the fact that we didn't do the homework to identify that the individual lived in a two-story house and couldn't go upstairs. We didn't identify that the individual didn't have a support system and ended up being readmitted. That's on us. But the other unplanned readmission, and there are two types. The other unplanned readmission is the individual who was admitted for congestive heart failure and falls, goes home, falls, and breaks their hip and comes in for a total hip. A totally unrelated second admission. We're penalized for that. And then the third unplanned, is the next unplanned category I talk about, is really one that I said, how can you put on the hospital, but it's been put on us? And that's where we have to work on this continuum of care. And that's the individual that won't follow dietary restrictions. It doesn't follow medication compliance. And so we've really got to identify tools, technologies, strategies with community-based workers, the extension of it, other advanced practice individuals like licensed nurse practitioners. I know in some markets we're hearing about PharmDs and social workers working more in an extended role within their scope of practice to really provide that continuum of care and monitor that patient, or technologies that can help an individual realize that that pill box wasn't open when it was supposed to be, or the pill wasn't taken when it was supposed to be taken. So those whole issues of patient compliance do fall on us, and we've responded in a variety of ways, we being providers in the region, to help address that.
You had mentioned that Hospital Council focuses a lot on the C-suite, but I know that you also have other work groups. Can you touch upon some of the organization or type of professional that comes into Hospital Council to network together?
Absolutely. We work off of a committee structure, and the committees include chief nursing officers, chief financial officers, and chief medical officers. But in addition to Holly's question, we bring together HR professionals, the case managers, individuals who do managed care contracting. We bring in together risk and QA as one committee, the risk managers and quality officers as one committee. So we don't really get down to, we bring in patient account managers as well for the patient accounts committee. So we work off of a committee structure. We've recently brought together fund development officers. And so the intent of a regional association in supporting the C-suite and key management positions, bring everyone together in a committee structure. Within that committee, they're going to have some education, but basically they're going to be sharing best practices. They're going to be talking about what works and what doesn't work and why it didn't work. We may bring in some vendors with a product or with a technology, but it's really a time for individuals to come together. And the best way to, I think, differentiate what we do, Holly, between a state association, and I've used this example, it's starting to become a little dated, but Governor Rendell, former Governor Rendell, passed a piece of legislation that revamped the way infection control reporting had to be done at the hospital level. I think it was Senate Bill 14, don't hold me to that. And so the State Hospital Association worked to try to ensure that the wording in that legislation was not overly prohibitive or burdensome on hospitals, the role of the State Hospital Association. And once that became law, it went to regulation. And they worked with the Department of Health to try to determine the regs. And the Department of Health came out and with the Hospital Association with a very nice manual saying, here's what you have to do to comply with Senate Bill 14. Where we came in, Holly, and the value add for us was we brought in 120 infection control and quality specialists, and we went through that manual, and we talked about interpreting that, and we asked the regulators to come in and give us their interpretation. And we identified ways to come together to do a group buy on the information technology system we needed to report infectious diseases. And so that was really where, again, the support of the C-suite or the project management piece, and that came out of committee work, and it was committee work that was really driven at the department head level. Now, some of you may end up in markets, you may be on the supply chain side, the purchasing side of the house, where you will find associations or trade associations come together, and we'll bring pharmacy directors, lab directors, we'll bring imaging directors together to not only talk about clinical issues and talk about management issues and talk about regulatory issues, but to come together and talk about spend issues around supply chain management and to talk about pharmaceutical and formulary issues. So that's really, and I know, Holly, you've been active in our committees in your previous career opportunities, and that's really what makes us, I think, a successful association is membership involvement. So wherever you are, whether you end up in a regional association or you're with a large system, you will be convening, you'll have the opportunity to convene with your peers. You need to make those meetings, you need to contribute to those meetings, and you need to take away best practices from those meetings and those opportunities.
I think that hospital council's value added is that collaboration, that people of like minds coming together, not having to reinvent the wheel, and be able to share policies and procedures. And I know whenever MCARE came out in 2002, hospital council was very instrumental in getting the hospitals together to try to comply with all of the regulations, even though the state was very gray in what they were asking. You mentioned that you just pulled together the fund development officers. Fund, not fun.
Right.
Can you, what are they? That's a new animal.
Yes, it is. Well, and they do have fun as fund development officers. One thing that we picked up was, again, with the Affordable Care Act, with the reduction in payments, and with the downturn in the economy, okay, so they're coming, two issues coming simultaneous, that hospitals were finding that individuals providing gifts, donors, were diminishing. We are, as a society, individuals of our generation and a younger generation may be volunteering and contributing and doing charitable acts, but not necessarily through organizations like the Shriners, okay, or other entities that did fundraising and providing a nonprofit organization with the funds that they collected. And so so the light bulb went on with to me and with Pat Raphael, my Vice President of Professional Services, saying that the fund development officers are really starting to talk among themselves and said, boy, we're seeing a decline in gift giving. There are a variety of ways that we can raise funds for this nonprofit entity, being the foundation. And so let's start to talk about that. And so, Holly, it ended up being just like any other committee where best practices and shared successes and shared failures were all brought around the table. And so the fund development officers, Rich Mahoney from Washington Hospital, Mary Lee Gannon from UPMC St. Margaret, reached out to their peers and said, let's meet, let's start to talk. And from that, we brought in some national fundraising experts. We've looked at some products and some services. And that group is probably the hottest, your committee used to be the hottest committee that met at council.
Then I left, but no.
Yeah, right. And they are the hottest committee right now, and the synergy there is just outstanding.
You had mentioned that you, as a hospital council, you do legislative type of work. What is your involvement with the local congressmen and senators and Capitol Hill? How do you put that together?
Well, first of all, again for the students, we are a 501c3, a nonprofit organization. If you are going to be an entity that lobbies, advocates, and is lobbying and has an official lobbyist and a lobbying arm, you need to be a 501c6. And so all of your state hospital associations would be a 501c6. That's their primary lot in life. We do have another entity called HHI. It is our 501c6. So we are limited in what we do. We really take our lead on state issues from the State Hospital Association. So the Hospitals and Health Systems Association of Pennsylvania, acronym of HAP, H-A-P, will work with us, and because it's a large state, we will reach out and work with local representatives and state senators on issues, and we will also obviously work with our members of the U.S. House and the Senate, representing and trying to cultivate what the concerns are in Western Pennsylvania, or to simply provide the message that is statewide on healthcare, and do that in a regional setting. So we really are, Holly, an arm where we help support and assist in that area. We really do not address issues on the state budget. That is the role of the State Hospital Association. But with the issue of area wage index, our board has said the entire state of Pennsylvania is not affected by wage index. It's the western part of the state. And so that is why we specifically are taking lead on that matter. And so I am going to Washington, D.C. next week. I will be there as part of the American Hospital Association's Regional Policy Board, Regional Planning Board meeting. And we will go through proposed strategies coming from the AHA on all kind of issues, all kind of legislation, Affordable Care Act and other CMS regulatory matters. And we'll have round robin discussion on that, and we will talk about strategies and the pros and cons, cliffs and valleys that we see in moving forward. And then out of that will be an assignment to work with our local House rep and or our state senators on that particular issue. I'll probably go down and visit with a couple of lobbyists that will engage to talk about wage index, so I do get a chance to go to the Capitol once in a while, and I find that enjoyable as well, but again, I'm not a full-time lobbyist, nor would I think my strengths or the strengths of our organization are in lobbying.
Hospital Council, you had said that the hospitals are members. How do they become a member of Hospital Council?
It's a dues-based trade association, so much like the Society of Engineers or any other society, professional society. We have individual societies you may belong to. I belong to ACHE, some of you may belong to the nursing execs, you may belong to HFMA, the Finance and Managers Group, MGMA, Practice Managers Association, but it is a dues-based trade association, and for those dues dollars, we provide work on their behalf.
Perfect. Now what would you say the most enjoyable part of your job is?
Most enjoyable part of my job, I think there's two things that come to mind. One is I work for a great group of men and women, and those are the CEOs of our hospitals, our post-acute care facilities, and our long-term acute care facilities and specialty hospitals. It's a great group of individuals, Holly. I mean, the pressure, as you know, the pressure of a C-suite team to run a hospital, the regulatory issues, recruiting physicians, moving to this whole value-based payment system, working in the community, working with your trustees. I'm so impressed with the work they do. It's a privilege to be able to work with them, and I really find the greatest satisfaction of working for and supporting those CEOs and their C-suite team. The second most enjoyable thing is, and this was a factor in my taking the job, was I love geography and I love Western Pennsylvania. So I enjoy driving around and seeing the different geography. So if I'm going from Clarion to Brookville, I won't take Route 80. I'll give myself enough time to work the back roads because I do enjoy the scenery. I love Western Pennsylvania. And so you're on the road a lot, and I'm not flying. I'm not a road warrior. Some of you may be with consulting firms or with other firms where you're on the road flying. Most of my time is behind the wheel, visiting my member organizations in the 32 counties that we represent.
What would you say the least enjoyable about your position?
Least enjoyable would probably be conflict resolution. I think that's common for all of us that have come through management. It's always the hardest as a frontline supervisor to discipline somebody, and you do have conflict issues that arise, not between members necessarily. As I mentioned, even with the Highmark UPMC issue, we are a neutral convener, but we do have issues with the health plans at times. We may have a difference of opinion with the State Hospital Association. We could have a difference of opinion with the legislator on a matter. So I would say the conflict resolution has always been, in my career, the toughest thing for me.
Now, as far as projects that you've been involved in, what would you think, looking back on your career, what would you see as what you would be the most successful project?
Good question. I think that there were two projects that I'm most proud of that I think were very successful. It was during my time one in Cleveland. My first one, I was at the Cleveland Clinic Foundation as the administrator for medical operations. And all the way back, Holly, in 1989, 90, 91, we're going back a while, we were implementing a cost accounting system from a company known as TSI, which was out of New England. And they had some clinicians who worked with the finance people, and we created they created a clinical decision support tool. And this was the first time where we could go in and work with the medical staff and demonstrate and show the medical staff, not on charges, but on actual utilization at the cost level, where the spend was for caring for their patient. So that was one issue to look and say, well, here's where your cost is. But we were also then be able to look at variations in care. And we were able to look that within a department of neurosurgery or department of urology, why were physicians doing something different? Why were they ordering different? Why were they utilizing an ICU differently? This was cutting edge, and we were able to, in essence, reduce clinical variation at the clinic by sharing this information with the various departments. And to be part of that and to be in the room with world-class surgeons having these discussions was just, and making a difference in length of stay, making a difference in reducing costs, but making a difference in improving outcomes, improving processes of care, was very gratifying. And then that was followed when I left and went to the Greater Cleveland Hospital Association. If you go online and look, you may find about the history of the Cleveland Health Quality Choice Project. And the Cleveland Health Quality Choice Project was the first risk-adjusted outcomes based initiative in the country. Outside of Mark Chesson in the state of New York doing the report on bypass surgery, we were the first in the country where the business community, through Cleveland Tomorrow, the Chamber of Commerce, and the benefits managers, got with the medical societies and the hospitals and said, we want to see risk-adjusted clinical outcomes data on COPD, CHF, pneumonia, surgery, etc. We want to see length of stay. We want to see patient satisfaction. And so, Holly, when I look and we see all of the core measures and all the risk and all the quality measures and initiatives that are out there, we were a pioneer in the Cleveland Health Quality Choice Project, and that's something that was way before its time. It closed and ended up closing for a variety of reasons. But you know, what goes around comes around, and we look back, and 20 years ago we were doing what people are now doing, and that was very, very satisfying part of that project.
Well, your first example to have standardization, hospitals are trying to do that now to figure out why one doctor charges more than another or more services, so that definitely was cutting edge. Now, when you look back on your career, what changes would you have made?
Well, you know, you get to a certain point, you realize that it's not your plan. You know, you follow the plan that's set before you, and so what would you do differently in your career? And I thought about that, and I would say that I love my career and I've enjoyed what I've done, and I'm here obviously back in Western Pennsylvania for a reason. I would say though, Holly, and I would say to the students that one area that I wish I would have been in tune with earlier in my career, and I would drill down on, is the accounting and the finance. There's a famous quote from a previous sister who was head of the Catholic Healthcare Association, I believe, no margin, no mission. And so in Holly and I's career, we've always had the issue of the finance guys saying we have no money and we have to make cuts, and the people in the clinical and support settings say, I need this. But you really need to understand, and I would say, Holly, that to have a better understanding of financial statements, to understand cost accounting, and to understand the whole reimbursement realm is very critical. I don't care where you are, whether you're on the clinical side as an administrator, whether you're a department head, whether you're in an outpatient group practice, you need to understand those financials, and you really need to move that to the forefront. I was always the one who said, oh, I really don't want to take this accounting class, or I'm really dreading this quantitative analysis class. Mm-hmm. And I will tell you that that's where I would have focused more in my academics and also early in my career, and I would encourage you to do the same.
And I would have to echo your remarks too. I was always on the quality side trying to fight the finance guys to give us more money.
Right.
In closing, what advice would you give to the health administration students as they get into the healthcare arena, and maybe the first opportunity that they've been? What advice would you give them?
Well, I would say to you, first and foremost, what my father said to me, and when I went into every job, whether I was a supervisor, department head, or administrator, when I took that job and I met with my employees, I made it very clear I had two principles, right? And those were to gain respect, you give respect. And number two, you never belittle someone publicly, you use constructive criticism privately. And if you're working for someone that can't abide by those two tenets, you really should look for a new job. Because why would you want to be subject to that type of management or leadership? Because life's too short. That's the premise. Two, it's all about communication. It's about common sense communication and working with your people. Those are the basic tenets of what you need to do and should always do. I would say that the other story I'll give you is an analogy I give about my grandfather when he came over on the boat from Italy through Ellis Island. He did not know how to read or write. He memorized what he had to memorize to get through Ellis Island. And he never learned to read or write, so he was in essence illiterate. And so I look now at today's society, and I consider myself illiterate as it relates to the new technologies. And so staying up on those technologies, and many of you are millennials, and some of you are along the different continuum of care, but not only those technologies for yourself through your smartphone, but understanding the technologies that are on the cusp of coming out in healthcare. And the fact that CVS, Walmart, other entities, other organizations that were never in the healthcare arena are getting into the healthcare arena. And for that, you can, one, look at opportunities there, and number two, recognize that that is a threat and it is competition to the traditional care delivery system. And so it's all about understanding and staying up and maintaining those technologies. So those are really two things that come from the heart I would share with the students. And again, as you proceed through your program, wherever you are, and whatever market you're in, I do think it's about networking, and it's the opportunity to identify and meet with a chief executive officer, a chief nursing officer. The other thing to look at are retired administrators that you may know that are out there that can give you their wisdom or give you their perspective on the healthcare setting. And again, I have to think about the fact that coming through Holly, we came through kind of the traditional hospital setting where I've always thought about the hospital as four walls, and I've thought about an organization. But many of you are going to go into consulting, you're going to go to tech companies, you're going to find a variety of opportunities, practice administration. You're going to find there are new endeavors, new service lines, or the whole supply chain arena. So it's an exciting time, and there's a broad scope, and I always forget about that as I'm talking to you, that there's more than one way to pursue a career in health administration. Mine is more traditional and possibly outdated, but it's there, and I'm excited for you, and still excited. There will always be opportunities in healthcare. It's not recession-proof anymore. We thought it was, and it's not. But there will always be opportunities out there in the healthcare arena.
When the individual comes to you on an interview, what are you looking for a prospective employee? What characteristics are you looking to see?
Great question. My interview questions I developed over the years. One question I never ask. I just despise this question. Where will you be in 5 years? Who knows where you're going to be in 5 years? Who knows what you're going to do in 5 years? I am more along the lines of tell me about your strengths and your weaknesses. If I were to call your past supervisor, what would they tell me you did well? What would be an area that they would tell me you need improvement in? Then I'd change that same question and say, what area do you think you need improvement in? Obviously, I'm looking for good eye contact. I'm looking for a sense of humor. I know that when I was hired by my first boss, she said, I was looking for a strong B student, and that was you. I'm working for the individual who's well-rounded, who can really communicate and interact with people. And again, respect people, show respect. I'm going to assume you have the technical competencies, and if you don't, we're going to help you develop those. So it's really a fit for the job. And I would say to you, if you're not quite comfortable for the job, maybe that's not the job, and it's easy to say, and you're coming out of school and you have some debt, or you're expecting to find that first job, and it will come. You may be doing something. I'm reading now that people obviously not only change jobs but change careers now. And again, I think with the training you have out of this program, and with the skill sets you have, as well as those of you who have already experience in the field, a variety of opportunities, so.
Perfect. You got, having the clay to mold.
Right.
Any final comments you want to make as we wind down?
No, I just think that I appreciate the opportunity, Holly. I think obviously the online learning is again a technology that wasn't there when we were there. I know you're making the most of it. I would say that if you're in the Western Pennsylvania region, you're more than welcome to direct your resume, CV to me at the time when you're looking. Be glad to talk to you. It's all about networking. And whether it's myself or one of my vice presidents, we'd be glad to help you out in any way, shape, or form that we can.
And as I've said to the students, the only thing certain in healthcare is change. And to be an agent of change makes it a lot more successful and easier to maneuver the changing landscape. But this concludes our Day in the Life of with A.J. Harper, and I want to thank him for his time.
Thank you, Holly.
Thank you.
And good luck.